groups, raise your hand. I guess should have both of them. Right? Okay, so the first slide, if they're, Brian, you think you have them going here? Yep, here they are. So this is health plans on blood pressure, focused review that you see here. And basically, if you go to the right-hand side, it's improved over time. You see all of the green. And in particular, look at Sharp. Anybody from Sharp here? Raise your hand. Great work. You're still working on it. No one here. So, keep going. Western Health Advantage, and I saw Don, I think, earlier. So great increases there, as you see, 12%, 10%, and so on. Kaiser's still high as well. So overall, it's good. But if you look down below, the California average, is above the national average, but fairly much below this 90th percentile overall. So still a ways to go. And one of the ways to look at a lot of the Hector now will be presenting 60, 70, 80% is the one minus. Right? But what is it about the 20%? Is it something about the patients, where they live, something we need to do differently in order to get that part of the population? The next slide is going to be medical groups.
So I'm going to show two slides. The first slide is Northern California groups, where the University of Best Practices are. And the second slide in Southern California. So in this slide, we have the parallel measure that just for all patients, blood pressure control. And as we can see, the 90th percentile of national performance is 74%. And as you can see in Sacramento, we have two groups that exceed that, Sutter and UC Davis. And we have in Santa Clara County, two groups also that exceed that. Kaiser Permanente, both of their sites, the Santa Clara site and the San Jose site. As you can see from this graph, we have several other groups very close to the 90th percentile mark. So, but I think one thing to note is that there are some groups that have high variability. And some of the variability could stem from data collection. We know that. And getting routine electronic health data. So I would say that on the Santa Clara side, you see those numbers not reflecting that everybody's out of control. It's more so that blood pressure wasn't assessed and tracked. But if we don't track, we don't know. Now we go to the Los Angeles figures. And as you can see, more heterogeneity here in Los Angeles. Again, the 74% under control is the standard 90th percentile. And as we can see here, we have Kaiser LA exceeding the target, but many groups, including Cedars-Sinai, and I could say UCLA Medical Group, very close to that. In San Diego, we have our highest performer in the state, in Kaiser San Diego. And as Patty mentioned, this wasn't always the case. They came up from low in the pile in terms of San Diego performance. And you also have three others meeting the performance 90th percentile in San Diego: Scripps Medical, like Scripps Coastal Medical, as well as Sharp Stealing Medical.
Okay, moving back to the health plans, here you see it for people with diabetes. So now this is targeting diabetes at the plan level and controlling blood pressure. You see a more mixed bag in terms of improvement over time since 2011. You see some of the red lower right-hand corner there. There was a big increase. Sharp, again, 14% increase in the work that they're doing there in the health plan part of Sharp in San Diego. You can see, other than that, there's kind of not a lot of room still to improve. The California average is below the 90th percentile, as you see there, although again, generally above somewhat the national average, but below the national 90th percentile. So again, we have to think about what it is that plans might be doing as they interact with the medical groups that they contract with to change some of these numbers. So we're going to go back now to the medical groups, both in Northern California and Southern California.
Great. So it actually is pretty interesting. When you look at just diabetics, there's different groups that exceed the threshold 90th percentile, which is at 77%, so a little bit higher for diabetic patients than 90th percentile. But here in Sacramento, we actually have Sutter and Sutter IPA, both exceeding the 90th percentile in blood pressure performance for patients with diabetes, which is commendable, as well as UC Davis. So we do have the top 3 performers in this area here in the room. Congratulations to them. And in terms of Santa Clara County, we have the Kaisers again exceeding performance, but also Sutter Palo Alto Medical Foundation as well. And again, we have the data reporting challenges for some smaller groups and IPAs. Again, this is commercial performance. In terms of Los Angeles, we see here that for diabetic patients, blood pressure control is at the 90th percentile for Cedars, but exceeds the 90th percentile for Kaiser LA. And in San Diego, we see again Kaiser San Diego, Scripps, both the medical group and the Coastal Medical Center, as well as Sharp Steely again, exceeding the 90th percentile in blood pressure performance for patients with diabetes.
So this time we're looking at the health plans. We're going to look at blood sugar levels now. On this slide, again, in the lower right hand, I'm focusing on the improvements or changes, in this case since 2012. And we see actually some decline, small percentage-wise, but nonetheless there are a couple of exceptions. That Health Net has increased, Kaiser Permanente has increased in terms of blood sugar under 8%, percentage of people that have it under 8. But once again, if you look at the national 90th percentile, which by and large is in the 70s and high 60s, and the California average, we're under that. Data not available for the last 2 or 3 years. We'll be filling that in. We are somewhat above the national average, but below the goal we want of the 90th percentile. Some of that might be explained by what's going on at the medical group level, and so we're going to shift back to that.
Just to underscore that the 90th percentile here is a much lower performance level, 66 as compared to 74 and 75%. And in Sacramento, for the A1C control, we have 3 groups exceeding the 90th percentile of 66%. Mercy Dignity, Sutter, Sutter Independent, and Woodland Healthcare, so 4 actually. And then we have 4 groups in Santa Clara County exceeding: Affinity Medical Group, Kaiser Santa Clara, San Jose Kaiser, and Sutter Palo Alto Medical Foundation. So while performance tends to be low nationally, I think we have some standout performers here in Northern California. In Southern California, we do have multiple medical groups in LA County exceeding the 90th percentile for diabetes: Axminster, Cedars-Sinai Associates and Medical Group, Healthcare Partners Medical Group, as well as UCLA Medical Group and UCLA and Santa Monica Bay Physicians. In San Diego, almost all groups exceed 90th percentile. I think this is something that we see stand out in San Diego. We have Arch, Kaiser, Primary Care Associates, the Scripps Medical Groups, Sharp, both Sharps, UC San Diego, all exceeding the national 90th percentile of performance.
And moving to the LDL that you see here, controlling LDL under 100. And again, you see over time some of the changes here as well. 90th percentile is around 69 to 70%, and we don't have on this slide actually in California, but if you were to average that up, again, we would be under that. I didn't have time to get it on the slide. You see who has improved somewhat over time. Again, Kaiser Permanente North in particular has improved. But mostly by 2018, we're up around 88-85% in terms of the LDL, which is a good performance, particularly going back to 2006. So this is largely a success story. And some of the things we heard today from our speakers are being implemented. Although again, we can do still better. So back to the medical groups.
So just focusing on the latter part of the graph, the statin prescribing. This is focusing on that measure for measurement year 2018. As you can see, Sacramento County, we have 2 groups exceeding performance at the 90th percentile, which is really high. It's at 87%. So this is something health systems generally do well with. South Sacramento and Mercy, congratulations on achieving and exceeding the 90th percentile. In Santa Clara, it's Kaiser Permanente, both sites, as well as Physicians Medical Group of San Jose and Sutter Palo Alto Medical Foundation. And then finally, for Southern California, we have one positive outlier in this. As you can see, most performance is fairly high, though, although one UCLA medical group does exceed the 90th percentile of performance. And in San Diego, we have a bunch of medical groups that near the 90th percentile, but we don't have anyone exceeding the 90th percentile of statins, which is a fairly new measure for us.
What?
Oh, they get Mexican prescriptions. Undercounting.
So this here is a slide just to remind us of the famous triangle that we have in terms of package of interventions, right? In terms of intensive ambulatory care, the home blood pressure monitoring, examples, proactive outreach, pharmacists on the care team, very days of success and UC data that Donna talked about, is putting that pharmacist on the care team and so on. Some of the protocols there as well, some of the efforts on patient activation also. So what we want to do is move now to some discussion questions. The first one's going to be around insurers. I'll kick that one off, and then we're also going to talk about medical groups. We've got microphones, and this is really going to be a discussion for as long as Hattie, you and Dr. Thompson think we have time to go on this. But high-performing health insurers tend to have more exclusive relationships with physicians. In other words, we went back through the slides that Hector and I had just shown us, right? You would see that they tend to have these more exclusive relationships with physicians. Kaiser, of course, not directly employed, but the permanent medical group is exclusive. Sharps, physicians, etc., and some of the others are more exclusive with that particular health plan. So moving forward, will improved performance require, do you think, more exclusive relationships between health plans and physician groups? If people are going to, begin to line up in given areas of the state with a particular health plan, or do we need still, where there'll be a part of many different health plans, but might we need more harmonization or standardization in order to make more progress? So welcome your thoughts on that, particularly maybe some of you that are parts of medical groups where we really contact with a lot of different plans. By the way, the big 4 plans in the state, of course, Kaiser, 40% of the market alone. Blue Cross, Anthem Blue Cross, right? Blue Shield, sure, Blue Shield. And then HealthNet, Centene now, Centene, HealthNet, Centene. Others important, I'm not, Western Advantage, we do have others, but those big 4 account for about 70-80% of all Californians right there. So if we could do something with those big 4 and the medical groups they work with, would we make more progress? What are your thoughts?
Stephen, can I go?
Yeah.
So the 2 people here on this table of panels is Blue Shield and HealthNet, which I think were the first few plans who got an exclusive team of regional medical directors who were hired from the provider group side. They understand the function, they understand the operations, they understand the pains, and partnered really, really well with all those delegated groups. The relationship is very different than what an insurer delegation oversight would have with a group. It's very collaborative, it's very talk to me, how can I help? Where do you see gaps? What are the best practices? This is what I've seen with other groups. Do you think this would work with you? And then we fund a lot of the initiatives. So I think it's the only way to go. They are the PCPD orchestrator of care for the members, for the patients, and you have to partner with them.
No.
I hope that just to underscore the question, though, it's the exclusivity, the more dedicated relationships between physicians and insurers. We see that breakthrough improvement on these measures happens when that's the case. Western Health Advantage, Charlotte Health Plan, the Kaisers. And the question, we see stagnation for the most part in other types of health plans. So the question is, what is it going to take for these large, heterogeneous, lots of different contracted health plans to improve their performance? Is it through exclusivity, or is they going to have to do something different?
Scott, you want to?
Yeah, sure.
Scott Flynn.
Scott Flynn with Blue Shield, California, one of the regional medical directors. I would agree that there are some huge advantages when you have the employer-employee kind of relationship. They're not directly employed, but they are. You know how it works here with foundations, et cetera. One of the ways we kind of try to break that paradigm is with a couple of our partners on this, and we don't see it on the health plan overall, but we've seen it work for certain providers, as Amy was just describing. And that's really developing that partnership relationship that's similar to a foundation model, but it's really not. We've done that with Scripps, Hill, with some other characters, and we saw some of those results up there with Scripps, Mercy, and Scripps physicians. They're at the 90th or greater than 90% all vendors, and they have many other health plans they work with. So it is possible to do. I think part of it is, and that's part of my talk when we get in here in about 5 minutes, is getting the providers engaged, which is the very hard part, and then getting them to actually implement some of these very basic quality improvement programs. And first they have to care to do it, and then they have to execute it. And we're here to help, but we can't do it ourselves. Parag has done that at Mercy and at Sharpie Stealing, now I assume with UCSD. It is possible to do with a number of different payers. It's not a necessary thing to have that type relationship with the foundation. You can do it otherwise, but it takes a lot of work and effort and dedication to do it.
So what I hear, part of it really then is the clinical leadership on the physician side, the physician group side. So maybe the solution is to send Parag around the state. Yes, yeah, Dr. Buss.
Yeah, I was just going to say that, so if you can hear me easier. We work really closely within Sutter. We have a large integrated group, but we have many independent physicians and non-independent physicians, and they're not all, exclusive relationships. And we've had lots of success. And I think the key to success is really having the physician be part of the care team, having the physician and the patient be part of the same care team, and having whoever it is that you're doing this work be part of the care team with the physician and the patient, so that you're aligning your goals, all working in the same direction, and to the extent possible, unburdening work off the physicians and not having extra work onto the physicians. As somebody once said, no physician wakes up in the morning saying, I want to cause harm, I don't want to do the right thing. Everybody wakes up wanting to do the right thing, wanting to take care of their patients, but you got a million things to do every day. So how can you do a better job? You can do it by having a team that is together taking care of the patient, and that often means being within the same electronic health record. Because the electronic health record is like the doctor's, it's like, I like to say, it's like the doctor's knowledge of the old days in the hospital. It's where things happen, it's where communication happens, it's where patient care happens, and so we need to be able to communicate with each other at the level of the patient, and the patient and the physician need to be the center of that work and part of the care team. That's my experience.
Great. Thank you. Maybe just the second question here also is to call out and highlight the work of the Integrated Health Association, IHA, which many of you are a part of or know about, around standardization of encounter forms, of billing and claims processing, and in particular of the quality metrics, of which we have too many currently. So IHA is working with a lot of the health plans and the medical groups that are around the table trying to do that. So if we could get the big four in the state and others, the big 5 or 6, to do that, I think that would help, even without necessarily having totally exclusive relationships with physicians. It would help a lot. And maybe make the job of some of the clinical leaders to step forward to engage, as it were, with the plans on some of the things that are needed. Over here, yeah. Jose, do you have the mic there?
Yeah, thank you very much, Steve. But I wanted to underline what Kim said, because I think some of the successes we've had, because as she mentioned, one of the challenges is to have an integrated medical record that helps communicate. So the exclusive groups have the opportunity to use that, and it's a tool that can bring you huge success by identifying patients and identifying measures. So that's a key piece. So one of the things that you've seen with the IPAs is that the IPA model, we're constrained by the fact that most of us aren't able to have 100% deployment of one electronic medical record. Therefore, we have to then work around it. It becomes very challenging when you have, like in Sacramento, like in our IPA, you have about 40 or 50 different EMRs. There is no integration, and we worked pretty hard in Right Care on time to create what I call a capital HIE that never happened because of the cost of a bricks and mortar HIE. But anyway, that's a challenge we have to address. The other piece that I totally agree with Kim is that, you know, it's not about giving doctors more work to do. It's about trying to figure out what are the sort of opportunities to take resources and take work and create workflows where doctors can participate, but someone else is doing the heavy lifting by calling patients who don't show up. One of the big gaps is patients who never come see Dr. Jones, but happens to have diabetes, and what is she doing with the diabetes or her hypertension? And we need to reach out, and you know, it's not the doctor really doing that work, but having people like, you know, Annie Tsai and her IQS program that does an outreach to that population and tries to reach them even in odd times to be able to bring them in and get them engaged. So that's a big challenge, but I think nowadays as time goes on and with the pending physician shortage that we have, and in some places we already have it here, is trying to figure out how do we, you know, address the biggest issue right now in healthcare, and that's burnout for physicians, and how do we do that in a way that can help the physicians and can help the systems and can help the patients to be able to get the care that they need. So, thanks.
Thank you for that, both good points. Don in the back there?
And then I'm sorry to interrupt, but I think from there, we're gonna have to go on. We'll have more time for discussion, but we need to have a couple more folks from the health plan side speak, and then we'll have some more time for discussion.
Sounds good.
Yeah, on the paper performance program, I sat on the governance committee for years. And when you take a look back, they used to have some measures on IT infrastructure, and there was an absolute direct correlation of the medical groups that did well on quality and those that did well on the IT infrastructure. And really, I think the key is getting the infrastructure. We're getting better IT in place. Now we even need more personnel infrastructure to support the primary care physicians along those lines. And I think that's really key to it. And from our standpoint, it's just making sure that the payments line up with all that. So there's good value-based payment structure.
Thanks, Don.
So we'll leave you with this to think about as the next two presenters speak, and we'd love to hear the discussion after. But how should we work together moving forward to improve health plan and medical group performance on these measures? Is the current approach, these university of best practice models, working, or do we need to do something different to get to goal? So thanks for your thinking about this as we hear the next presentation.
Thank you all, and with that, we'll turn it over to Scott Flynn, who's going to talk about the health plan experience from Blue Shield of California.
Afternoon, everyone. How y'all doing? Good. So I'm the Blue Shield expert for Right Care. You all know what an expert is, right? Somebody from out of town with slides. Here's my slides. All right. October of 2015, we were mandated by the Department of Managed Healthcare to participate in the Right Care Initiative to develop a plan with a goal of achieving the 90th percentile of the RCI metrics by management year 2018. So in 3 years, we were supposed to go from care equivalent to 90th percentile. Right? Easy to do, right? Okay. So here's what we've done so far. There is some evidence that the Right Care Initiative does work, can save lives and save money. There's been 2 publications out now from the efforts in San Diego that shows that you can reduce heart attacks, particularly not so much strokes but heart attacks by doing this. Betsy, you showed the slide about how hypertension control has a near-term effect, and that's really what we're focused on there. Providing this care is worthy of our family and friends. It's sustainably affordable and meets those goals for our company. We're getting better health care, and we're getting it at a lower cost because we're saving money by not having to have people go to the hospital for that care. So what was our Right Care Initiative strategy? Well, health plans don't deliver care. Our partners do, provider partners. So we had to devise a provider engagement tool. And that's a tool that we have, a slight PowerPoint presentation, about 30 slides, pretty short, And basically it goes to this, it's, do you care about your patients? And all doctors are gonna say yes. Do you think you're doing a great job? All doctors say, yes, I'm at the 90th percentile. All of my doctors are, right? No, that's not true. They are. And then we show them their numbers about where they actually are at. And we say, you know, there are people that are dying every day from stuff that we can prevent. That's why we're all here, right? 80% of these are preventable. Patty, what does Tony DeMario always say? We all gotta die of something, let's not die of something stupid. So let's not die of a heart attack. We don't get to, you know, we have to control our blood pressure, take care of our diabetes. So
What else does Tony DeMario say? If you don't want to be the smartest one in the graveyard,
Yeah.
you
Yeah.
can't spell the L less than
Right. So we developed that engagement tool, and with many of our partners, we were able to engage them with that. And it's again, a nice short presentation. I go, oh yeah, now I get it. Then you have to give them some way to do this. It's surprising to me that basic QI work, quality improvement work, is such a hard thing for people to do programmatically. The standards are out there, the kind of how you do it is pretty well set out there. You gotta measure what you have, you gotta figure out where you are, develop some processes to work on it, and then check and see if it did something, then you come back and do it again. That basic QI work, when it comes to hypertension, you know, it's not sexy, it's not, no harm intended, it's not removing the clot out of the brain, right? This is basic, grinded out primary care work. And it's not sexy, but it's absolutely essential. And it doesn't have a symptom, except for when you get a heart attack or stroke, right? And so that's the other hard thing we're fighting with this, but it's something we absolutely have to do. Something else we did to help spread this throughout with our provider partners is encourage our providers to attend university best practices. As Hattie alluded to earlier, in LA, that's quite a challenge. Big geographic area, 14 million people. It takes about an hour to go a block or so, so it's hard to get there. So we're looking at other ways to spread those best practices virtually, doing virtual meetings every other month. And we also funded the Bay Area Silicon Valley UVP. So another step. There were 3 population areas that were covered before: San Diego, LA, and Sacramento. None in the Bay Area. Where are we headquartered? In the Bay Area. Well, geez, that makes kind of sense for us to go ahead and get that started and help funding for that. We also provide other support through quality incentive programs. A big part, I heard that mentioned a couple times a day, enabling the pharmacists as part of the care team, absolutely essential. There's stuff that they're licensed to do and can do very well, especially with the collaborative practice agreements. Get them out there, get them doing great work. Pharmacists actually, quite frankly, are much better at hypertension care than a lot of providers are. They pay attention to that detail, and they really get down to the nitty-gritty on doing that. So that's been a huge thing that we've encouraged. And we also had our own internal corporate employee incentive tied to hypertension and diabetes control. We had 3 quality metrics that we got for our incentive program for employees. Diabetes control is one, and hypertension control is one. The other one is reducing readmissions. So we put our money where our mouth was. Here's our engagement presentation. Does this get your attention? Okay. Yeah. And where do we get the data from that? From our buddies at Kaiser. Yes, this is from Jim Duddle. He's the head of the National Diabetes Campaign at Kaiser. And this shows you that if you treat high-risk patients, you can reduce their risk of stroke and heart attack, major adverse cardiac events, 17% in 2 years. That's near term. That's not something that takes 7 to 10 years, which people commonly think about as their primary care doc. Oh, I'm going to treat this diabetes and hypertension, and 10 or 20 years from now, I'll see an effect. No, 2 years, 1 in 6. Now, a high risk, what's a high-risk patient? It's someone over 55 with uncontrolled hypertension. That's all it is. Okay? And the bundle you give them is an ACE, a thiazide, and corticosteroid. Pretty simple to do. What happened in San Diego? This is again published data, looked at it, the reduction in the stroke, in the heart attack is the table on the left here. Here's the reduction in heart attacks since the start of the right care initiative in San Diego, 23%, statewide 7.6. We don't see a separation here across the state, but you can see the dramatic drop in there also that happened on both of them. So, and that was confirmed that the trend continues, as Hattie alluded to earlier, that we're doing better and better. So, self-evaluation tool. The tool is not what's important to see what each one of them is, but what we did was, as we're doing our quality improvement work with the groups, we did the self-evaluation tool and said, here's the key things you need to do to actually move the metric on this. And we gathered this from all the university best practices, from working with other groups, Million Hearts Campaign, AMGA's Measure Our Pressure Down, we came up with 4 different categories. You can see those there. 23 items for hypertension and 19 for diabetes. There's a lot of overlap, as you can imagine. And we made 3 rating scores. And we made it very complex. It was yes, no, or maybe we do it. Okay? Keep it very simple. And you look at it. Then you just form green if they're doing it, yellow if they're kind of doing it, and red if they're not doing it. And then when you do that, and we also highlight what are key and essential things to do, and they do that, you get a